Hey guys, welcome back. Thanks for joining me for another lecture series. A few of you have actually requested a video on ventilator physiology and modes, so thank you for commenting and making requests, and hopefully you can learn a little bit about that today. So today what we'll be covering is firstly some physiology important to ventilator function. We'll talk about the indications of ventilation. We'll talk about some complications, and then we'll go into some of the physiological changes again. So we'll come back to the physiology, and that's in this part 1, and then in part 2 we'll start discussing some of the basic ventilator modes. Great, so let's start with the alveoli capillary unit, which I've drawn here. Importantly, oxygen diffuses from the alveoli into the blood, and conversely, carbon dioxide diffuses from the blood into the alveoli, and this is essentially what happens during respiration. Now, we're going to focus just on these two molecules and their effects. And so, the volume of carbon dioxide that we exhale more or less corresponds to the respiratory rate multiplied by how much you're breathing, or the tidal volume. Now, that's the respiratory rate times volume, that's tidal. And this should intuitively make sense, because as we increase the amount of carbon dioxide exhaled, well, the lung can either do that by increasing how fast we breathe, or it can push out more carbon dioxide via the tidal volume. And so this concept of tidal volume multiplied by respiratory rate gives us the minute ventilation, and that's an important concept there. Minute ventilation is equal to respiratory rate times the tidal volume. And what you will find is that it is this minute ventilation that is important for driving off carbon dioxide. Now, this is not technically strictly true, because our entire tidal volume is not actually responsible for gas exchange. It's only the air that's kind of contained within these diffusing alveoli. We have some area of the airways that are not taking part in gas exchange, and that's the dead space. And so to remove that, the technical term is the alveolar ventilation. I'll call it AV, which is the respirate times the tidal volume minus the physiological dead space. And that's very small. That kind of forms the trachea and the main bronchi and the nasopharynx, because they're not involved in gas exchange. Now, considering oxygen, if we were to increase the amount of oxygen in this alveoli, like so, well, the diffusion gradient or the concentration gradient is going to increase, and we're going to get more of a diffusion into the blood vessels. And essentially, that's just increasing the fraction of inspired oxygen, so FiO2. So on room air, this is equal to 21%, and we can increase this FiO2 by giving patients extra oxygen in liters per minute from the wall, and we can give them through nasal cannula, give them through masks, and then there's other stuff such as kind of resulting in intubation. And we can increase the amount of oxygen in the alveoli, you're going to increase the amount diffusing into the blood. But actually, there is another way to increase the amount of oxygen diffusing into the blood, and that's with something called PEEP, and that is the peak and expiratory pressure. And this PEEP, so what is PEEP? Well, I'm glad you asked. Now, let's imagine this alveoli at the end of expiration, and it looks something like this. Well, if you increase the pressure in the alveoli at the end of respiration, then it might look a little bit like this. Almost like a balloon that's been blown up a little bit more. And so what happens if we take this dotted line as the new boundaries of the alveoli, then there's actually more surface area that's coming in contact with the vessel. I'll draw it here as well. More surface area coming into contact with the blood vessel. And that helps to increase the amount of gas that can be exchanged across here. And conversely, or rather I should say, in addition, you can actually fit more of this oxygen in the alveoli right at the very end. And so at the end of respiration, there's a little bit more time, there's a little bit more surface area, and there's just a little bit more oxygen to diffuse out of the alveoli and into the lung. And this increased end expiratory pressure is what we call the PEEP. And the physiological normal levels for PEEP are measured in centimeters of water, and it's roughly about 5 centimeters of water. And we'll come back to that when we discuss the ventilator modes. So just to note that the peak end expiratory pressure helps to distend these alveoli, keep them open at the end of expiration, and helps to improve oxygen exchange. And very lastly, we'll talk about something called pressure support, and we shall put that pressure support. And this is simply just the volume of air that's pushed in, and it's supposed to kind of mimic a spontaneous breath. Mimic the spontaneous breath. And we usually start someone off, or a minimum, it's usually 8 to 10 centimeters of water. So about double what the PEEP is. Great, so now that we have discussed a little bit of the physiology, let's now start with why we would intubate someone, or rather why we would ventilate someone. And the way I like to go through these indications is kind of an A, B, C, D approach, and an A, B, C, D approach, and we'll start with A, B, C, and D. And the first one is the airway, and we need to protect and maintain the patency. Protect and patent. Keep it patent. So if a patient is not keeping the airway patent, or there's an impending airway kind of crisis, then we should intubate them to make sure that it remains open. B, for breathing, we think about respiratory failure. And there are two types. There's type 1 and 2, where type 1 is your hypoxemic and type 2 is your hypercapnic. And there are other instances for breathing, such as when there is poor compliance, such as in ARDS. So when the physiology of the lung is completely different to normal. Now, C, for circulation, we're thinking about minimizing oxygen consumption, or make sure that there is increased delivery to parts of the body. Increased delivery. And in the case of shock or sepsis, when oxygen, or I should say the oxygen delivery to the tissues is impaired, can be really useful in making sure that the body has adequate inspired oxygen and it's well ventilated, and that's why some patients may require mechanical ventilation. And lastly, for D, for disability, we think of neuroprotective considerations, and that is to ensure that you preserve an appropriate cerebral blood flow in cases such as trauma or traumatic brain injury, or where the cerebral blood flow might be otherwise impaired. And that leads us to thinking about the complications, which I keep in my A, B, C, D approach. And the first thing I think about is, with airway, is edema or damage to the larynx or the pharynx. And that's during intubations, where you can just traumatize the area, of course, kind of laryngospasm or edema to the areas. B, for breathing, is you'll have ventilator-associated pneumonias, and this is probably one of the most common. You can have barotrauma, where You can cause pneumothoraces from increased pressures associated with ventilation. And lastly, oxygen toxicity, when you have too high of a fraction of inspired oxygen for too long, your body is not able to kind of metabolize that, and you get generation of free oxygen radicals and other reactive oxygen species. This for C, we decrease the preload in the right ventricle and also the left ventricle, and we increase the right ventricular afterload. So we make it a little bit more difficult for the right ventricle to pump, and for what it's worth, we also actually decrease the LV afterload. So there are a few things to talk about, kind of revisiting some of the physiology, and I really don't want you guys to just kind of stop and memorize it. The stuff really makes sense when you consider kind of why these things occur and the reason for the physiological changes. So with that, let's get into the first one that I want to talk about, and that's going to be the compliance. And the way I think about compliance is essentially how much the volume can change of the lung given a change in pressure. And so it's kind of the inverse of resistance. And I think a kind of good conceptual thing to think about is if the lungs are really soggy and really wet, and that's such as in patients with ARDS, and the lungs, they require like a really, really high amount of pressure. Can you see that? They need this much pressure to really only change the volume by this much. That's the change in the volume. And because these lungs require such a large amount of pressure to make a small change, we call that a low compliance. So that's down here at this kind of area of the curve. Conversely, over here, you can see that actually for this much change in volume, this much change in pressure, you get quite a bit more volume. And this might actually be a little bit more vertical in patients with better lungs, but you can see that this is a higher compliance because the lungs are able to change volume, the lungs are able to respond to smaller changes in pressure and have greater changes in volume. And so in states with low lung compliance, it's really hard to change the volume and therefore to oxygenate and ventilate. And that is what leads to respiratory failure. So now thinking about barotrauma from before, the reason why we get barotrauma, and it comes from alveolar distension. So when we talked about PEEP, the end expiratory pressure, opening up those alveoli to help with oxygenation, a little bit of PEEP does this to the alveoli, makes them bigger, more surface area, and they stay open a bit longer. But if we continue to add a bit more PEEP, it might start to look a bit like this. And then if we get too much PEEP, what's going to happen is that kind of just blows there, and then that's how you get a pneumothorax. Great, now let's talk about the preload and afterload, or the hemodynamic effects of ventilation. And so again, going back to PEEP, you can imagine that at end expiratory pressure, that pressure there, that's going to affect some of the blood vessels a little bit. And I'll just draw them. If I draw them here, that's where they normally are. So if we are distending the alveoli, we're actually pushing on these blood vessels as well. And that's good because it decreases this distance, this diffusion distance. But if we start to distend it too much, you can actually see it starts to push into the space. And what you'll probably find, or what you'll see, is that it starts to actually decrease the amount of the size of the blood vessels. And therefore, what that will do will actually decrease the amount of blood that's able to return to the right ventricle. So yeah, this will actually decrease the amount of blood that's able to return to both the left ventricle here, and the right ventricle. Now, this alveolar distension effect is actually more responsible for the decrease in left ventricular preload, because it is these capillaries that form the venous return to the left ventricle, actually through here. The right ventricle, the venous return to the right ventricle, is mediated by the superior and inferior vena cava, but this effect is very similar. It's not due to the actual alveoli, it might just be due to the increased pressure in the thorax in general, which will make it slightly harder for the right heart to fill, but the concept is the same, where there's decreased venous return, and that leads to a decrease in right ventricular and left ventricular preload. Now, thinking about the afterload, or how difficult it is for the right ventricle to push against. Now, if the RV is kind of sitting here, it's having to push against narrower and narrower blood vessels. And if you remember, all of the millions and millions and millions of capillaries in series, that's going to be quite a large increase to the pressure that the right ventricle has to push against. So actually, the right ventricle has an increased afterload, where it's more difficult for the right ventricle to pump blood against all of that air kind of pushing on the blood vessels and the alveoli. Now, lastly, very quickly, we'll talk about left ventricular afterload, which actually decreases, and the reason it decreases is due to a decreased transmural pressure. And this is a bit of a difficult concept to get your head around, but essentially the pressure in the thorax is not transmitted to the aorta, and it's instead felt in the left ventricle. So the pressure difference between the left ventricle and the aorta, which stays the same, increases. And so it is easier, the concentration gradient from the left ventricle to the aorta actually increases, so it's easier to pump. Excellent. Now, that's a bit of a tricky subject to get your head around, and we will come back to it at another lecture, I promise. But for now, just trust me on that one. And we'll lastly finish off with the plateau pressure, which is more a measure. And that is the measure at the end. It's the pressure at the end of inspiration. And basically, if you take a deep breath in now and you hold it, the pressure that is felt in the lungs there, that is the plateau pressure, or the end inspiratory pressure. Great, now I think we have pretty much got everything we need in our minds to start discussing the basic ventilator modes. So thanks for listening. I hope you guys learnt a little bit, and I'll see you in the next video very shortly. Thanks so much for watching. See you later.